Hi, I'm Dr. Bone.
Hi, I'm Dr. Tartaglia.
Today we want to bring up the topic of being admitted to a hospice directly from the hospital. We've had some questions about how does that work, and so we want to discuss that a little bit with you today so that you can see it can be smooth and it can be seamless for you to go directly from a hospital to a hospice organization and make it really easy for the patient, for the family.
Yeah, and there's two ways normally how it does happen. Patients can be admitted to the hospital that are already on hospice services.
Mm-hmm.
So basically, what happens with those patients is they may have an injury or a traumatic event that occurred that requires hospitalization. So they were in the hospital and now they're going to come back on hospice. Or another way is they're directly admitted from the hospital to a hospice setting.
So let's break that down a little bit. Let's talk about the patient that's been on hospice and had an acute exacerbation that was too frightening for them to stay at home, or they had an injury that's maybe unrelated to their hospice diagnosis. Think of a heart patient that has, injured their knee, or has acute gout attack, or gets a bladder infection. And then they end up getting admitted for something that's not related to their hospice diagnosis. Typically, you're going to be discharged from the hospice while you're at the hospital, and you're going to receive the care from the hospital. And then when they have your infection under control, or they took care of your injury or infection or whatever you went for, then that's when you decide if you want to go back home and you want to receive that hospice again. Most people do. Many people have had a good experience with hospice, and so they want to go back on that service when they get home to help support them and help support their family. So typically, you go to the hospital. In the emergency room, or maybe by the time you've already gotten to the room, a hospice representative is going to come and have you sign some paperwork, and you're going to say, I don't want hospice anymore. I want to receive acute in-hospital care, and you just sign a piece of paper and it goes away. Then when you're ready to go home, that hospice is usually going to keep pretty close contact, maybe not daily, but pretty close contact with the social worker at the hospital for your discharge planning.
And they normally come in to do the discharge planning. It depends on the durable medical equipment that you need at home.
So if you were on hospice and you already have everything at home and you were just there a few days, probably that equipment is still there. And so the hospice representative will come back in, they'll talk to you, you're planning on going home, did you want our service again? And if you say yes, you'll sign some papers that say, I do want it again, and then you go home, your equipment's already there, and the service restarts.
Now, there is other patients that get admitted directly to hospice from a hospital admission. These are the more critically ill patients that, they just feel that they've not bounced back to their baseline, and it might be unsafe for them to return home without having added services.
That extra help. So maybe while the individual was at the hospital, maybe it's a person with a chronic illness and they've had one more exacerbation and now they've reached that point where they need the extra help. And life expectancy could be 6 months or less if they continue to have these events. And they've decided, gosh, I really want that extra help. Whether or not they want to receive code status, that is not dependent on that, but they want that extra help. So the primary team, you might bring it up, they might have asked you to see a palliative physician that's there in the hospital, and they will talk with you about goals of care, and then typically they're going to give you a list of the different hospice organizations that are in the county where you are, and you're going to select one. And then that hospice organization will come to the hospital, tell you about their services, and they can sign you up if you want to have that service.
And never feel obligated that you just go interview one. I always tell my patients, interview all the service providers in your community, because sometimes they might have different benefits, like pet therapy, for example.
Music therapy.
Some hospices may not have good access to these modalities.
And I'm smiling because, she's talking about interviewing them. And when you interview the company, you're going to see what's the face of the company, but it may not be the people who are going to deliver the service to you. You can maybe get a little bit of a tainted view. And I recently had a family tell me one of the daughters is, very tech and internet savvy. And so she said, I already know who's in our county. And I looked them up on Indeed. I wanted to find out what the employees have to say. Is there high turnover? How many stars do they have on Yelp? I've had patients who say, our church has a lot of people that are elderly, and I've talked to somebody at our church group, and they recommended this particular hospice. So you don't have to interview them in person. You can, dig them up on the internet. You can, look into them with friends or with neighbors. You can ask the hospital representatives. Typically, they're not going to advise you. Even hospitals that have their own hospice are really not supposed to just assume that you're going to accept their hospice. They're supposed to let the patient and family choose the hospice that the patient and family want. And I know the organization that I work for is very strict on that. We do not steer anyone to or away from a different hospice organization. We want the patient family to choose. And then, of course, you're not stuck with them.
Exactly.
But you can be, go from the hospital onto hospice service and right to home. We call that a safe discharge. So if the patient is on oxygen and needs a bedside commode, all of that equipment, maybe they need a hospital bed, maybe they need a walker, maybe they need a transport chair, but all of that equipment is to be delivered into the home before the patient ever leaves the hospital.
Right. And there are some patients that do not get transferred directly to home. Like some patients may live alone and it's not a safe transfer to go home. So there are several, patients that fall into that category. They may go to an inpatient hospice unit. And then others might actually go to a facility. Like they may have a discharge to a facility because they've require a higher level of care and they don't have the care at home. For patients that do go to an inpatient level of care, usually it's because they have symptoms that cannot be managed at home.
So the patient may be tired of being at the hospital. I've had patients telling me, I'm tired of being here. This is like a prison without bars. I can't leave. I can't go anywhere. My family's restricted on visitation. And so they just want to get out and they want to get to a more home-like environment, but maybe their symptoms aren't well managed. Maybe they're still short of breath. They're having some nausea, vomiting. Maybe they're still trying to get the fluid off of them and they're still trying to diurese them. They can go from the hospital to the IPU, the inpatient care unit. And an inpatient care unit is sort of like a critical care unit, but for patients with serious illness that want to receive their care in a more home-like environment, and they don't want that aggressive care. They don't want transfusions. They don't want, they want oxygen maybe, but they don't want to have, some of those, maybe those IV drips that they're getting for their heart. They want to try to simplify things and get as comfortable as they can, go to that inpatient care unit, achieve further stability in a more home-like environment that's maybe more conducive to family visiting and maybe even staying overnight, and then get back to their home environment.
Right. And then there are patients, unfortunately, that get admitted to hospice in a contract bed status, which means that they are not going to go home. They will remain in the hospital. And usually these patients are in the ICU setting of a hospital and they could not be transitioned out. And honestly, hospices will take patients even in the dying process to their inpatient unit. But say if their symptoms are so severely out of control that there's not enough medication to make them comfortable for the transfer, then they will stay in a contract bed status, where a hospice team comes to them into the hospital, but they stay in the hospital setting, and they will then pass in the hospital setting.
So, for instance, that I've seen before is a patient comes into the hospital and maybe their malignancy is advanced and they wind up on machines, and they did maybe not have clear directions given prior. Their healthcare surrogate either didn't know the responsibility or the patient was reluctant to talk about those types of things, and now the patient has achieved the level of a crisis and interventions are administered and the patient winds up on machines, but there's no possibility of cure and there's no reasonable expectation the patient is going to survive when those machines are removed. Now sometimes the machines are compassionately taken off and they come down on their oxygen and they come down on some of those drips. They're still giving them medications to make them comfortable, but now the patient has kind of reached a point of, maybe you could call it a coma, and they're not liable to ever be able to respond, but they're not on those machines, but life expectancy is only just hours, possibly days. And so they're critically ill and can't be transferred because the patient might pass away during transfer. And so they're going to keep them there in that hospital for the last few days of life, and the family can visit to whatever that visitation that's allowed by that hospital, but the patient might even just still stay in that same room depending on the critical status of the patient.
Right. And the interdisciplinary team, as we discussed in previous videos, they can come to the hospital and see the patient. But again, as we've been talking in previous videos and even today, I'd like to preach it. Just early referral to hospice is so essential because in those critical moments when you're talking hours to days, there's so much left out.
Yeah, you have to bring the patient and family from where they have been with their illness to where it is now. And particularly somebody with, heart disease or malignancy or a lung issue. A lot of times these are chronic illnesses that have gone on for a long, long time. And so it's a disservice to those people to not have offered them palliative care and to not talk about their life-sustaining treatment goals and, the concerns of what's important to you when your time becomes short. Where do you want to be when your time is at end? And so for some people, they never wanted to be at the hospital at the end of life, but because those plans had not been shared with other family members, unfortunately, that's where they wind up. They wind up being at the hospital at the end of life. And sometimes that's where end of life occurs. So it's not in a home-like environment, and they didn't get to achieve their goals because they were never really discussed.
Right. And it's sometimes then hard for the family because they're having to make all these tough decisions because they weren't discussed, as Dr. Bohm said.
When my parents were young, they both passed away when they were what I consider younger. My dad didn't tell us specifically, this is what I want, this is what I want, in this sicker circumstances, what you're going to do. He gave me general guidelines. And, I grew up in a rural area on a family farm that was small, but we raised horses and cows, and my brother had chickens. I was in FFA and went to VOAG classes, and so I'm just a little cowgirl that went to medical school. But he gave me guidelines that I want to be able to piddle around my farm, and I don't want somebody, taking care of me in a nursing home that wipes my mouth or wipes my backside, and then they don't know what order they wiped it in. And so he said, I want to be able to, be active and be mobile. So that was the direction that he gave me so that when the time came, I knew the decisions that he would have made. Now, my mom was a school teacher, and days way before the internet, my mom knew, I don't know how she knew the things that she knew. I don't know if she researched it at the library. I don't know if she had a crystal ball, but she knew about end-of-life decisions and care. And she knew exactly what she wanted in exactly what circumstance. And my brother was her advocate and made sure that she got exactly what she wanted. She wanted to pass away at home, and he made that possible. He made that happen for her. So you may have strict instructions as a surrogate. As a patient, you may give them, strict instructions of what to do under which circumstance. But then if you just give them general guidelines, and if the physicians involved will tell you, this is what the forecast is, this is what the prognosis is, this is what the trajectory looks like, then you can help make some of those decisions if your loved one is no longer able to speak for themselves.
Yeah, and your parents' story resonates with me because this week I had a patient of mine, and he demanded that he wanted this surgery because it's really wrecked his quality of life. Like, his quality of life has gone down, and he wanted to have surgery. And really, his cardiologist didn't want him to have surgery. The pulmonologist wasn't thrilled about it. But anyway, he got this clearance. But before he went in for surgery, he made it very clear and evident to his daughter, I don't really want, if they put me on a machine, get me right off. I don't want a tracheostomy. I just want, if I can't eat, I don't want a feeding tube and all these things. So he ended up in the hospital, recovered well from the surgery, went to rehabilitation, and then unfortunately had a catastrophic event at the rehabilitation center, went back into the hospital, now is on a ventilator, getting all the assistance that he did not want. So his daughter asked to speak with me because she was just curious of how everything stops, because she knew he does not want this. So I acknowledged her for being so strong in such a tough circumstance, because it's very easy to do all these things when somebody is living, awake, alert, able to make their needs known. But Dad's being sustained with all these pressors, which are medications to hold their blood pressure high. His kidneys are failing. He's not alert. And they, he's had so many days on a ventilator that now they're talking to her about a tracheostomy.
Wow.
So she said, nope, no to the trach. This weekend she has to go out of state for a family wedding. And she said, do you think my dad will want me to go? And I was like, well, what would Dad say?
Yeah.
If Dad could talk, what would he say?
What would he say now?
He would want me to go support my sister. So I said, well, then you go. You sign up all the paperwork for hospice. You fill out, that he's a do not resuscitate. And if Dad passes when you're gone, that's the way it was meant to be.
Mm-hmm.
So he's in a hospital setting, and he will transfer to their in-hospital inpatient unit if he survives the weekend.
Wow.
Mm-hmm.
So are they leaving him on the ventilator for the weekend, or are they removing the ventilator for the weekend?
That I do not know, but I have a funny feeling they probably will leave him just because he's being sustained by a lot of medications.
Yeah.
That I'm afraid if they were to take him off, he will pass. But I know the family has signed a do not resuscitate. So if he's to change settings or go into any kind of catastrophe, they just want him to die peacefully.
And that's how the organization I work at, that's how the hospital where I am will do it. So if the patient is receiving a lot of care and a lot of intense services, the family may say, this is it. We're going to bring in every family member. They can't be here for 3 or 4 more days. We got people flying in from out of state. We would like to sustain the patient as best we can with what he has right now, or she has, on those same medications. If they need a higher level of care, if they need a higher level of medication, we're not going to do that. If the patient passes away, as long as they're comfortable, even though they're receiving all of this care, we're not going to do any more. And we've kind of reached a point where we think that they would no longer want to receive further aggressive interventions, whether that's just going from oxygen by nasal cannula to a BiPAP, or from a BiPAP to a trach or tracheostomy. We're not going to do that. And families reach that point where this is enough. And we can kind of schedule or arrange for the compassionate removal of some of these machines to be done at a time that maybe is, I hate to use the word convenient, but maybe more convenient for the family, because people want to assemble for that. And I don't think that's unreasonable to do, because they are on these machines. And you want to take them off gradually, because if you just yank the rug out from underneath of them, suffering could be involved, but for certain the patient will not survive all of those removal, all those machines or all those medications to be removed. And so we'll let those drips run out. We'll remove that ventilator in a compassionate way to manage any symptoms that they have. And if the patient passes away before the family gets in, before they get back from the wedding, then that's what happens.
Yeah, and that's what's meant to be. So the way I ended it with the daughter is I told her, get your sister on the phone. It's her child that's getting married. Have her say goodbye to Dad. And when you leave to go out of state for the wedding, you say goodbye too, because you just don't know. No one is in charge of when our expiration date comes and when we pass.
That's right. So we can delay sometimes the very end of life, but it gets to that gray area between, what is living and what is alive. And that's where you want to have some clear direction. But if you've got an individual that's in the hospital, they are ill enough to qualify for hospice service, they can go right home with hospice. The patient can determine which hospice organization they want to accept service from and sign up right there in the hospital. Yeah. Then they would go home with hospice. They might go to a contract facility or an inpatient care unit with hospice. They could go to a family member's home for a few weeks if that's what's needed. Or they might be so critically ill that they have to stay right there where they are in the hospital for those last
hours to days
of their life.
So I think we covered a lot of good stuff in this video.
We did. I hope that answered some questions about how does a person get on hospice service when they're in the hospital.
Any further questions you have, we'll be happy to clarify. Thank you so much for joining us today. Bye now.